Let's get started. Welcome, everyone. I think I recognize a lot of names, but if we haven't met, my name is Emilia Andersson, and I am a pathologist and work for Roche Diagnostics Medical Affairs together with my colleague Anne Weidlich is also here, and we are proud sponsors of these workshops. So this workshop is being recorded, and you will also have access to slides, scanned images to score, and then we reconvene and compare results and discuss challenges. The recording, I think, will also be available on YouTube. So if you have any questions, feel free to put them in the chat or raise a hand and speak out loudly. Otherwise, I'll read the question for you. And without further ado, I'll give it to Corrado and Adelina, who will walk us through this exciting topic of PD-L1 in TNBC.
Thank you very much, Emilia. I dressed up nicely for you and I put my jacket on. It's very hot in here, though. Adelina has just finished to do reporting, and I tricked her into coming here. She hasn't seen this presentation, but she's presenting with me, so that's a little challenge for her. Let's see if I can do this. This is I got this one. This is kind of an agenda, more or less, so what we're going to talk today in the next hour. A little bit about what ICI are and what their use is in cancer, and a little discussion perhaps of what is triple-negative breast cancer, and then how do we do the testing for PD-L1. Although I promised Emilia that I wouldn't say that, but I am mentioning 22C3 because, of course, there is pembrolizumab on the agenda as well, but we are not going to talk too much about pembrolizumab and SP and 22C3. And then we're going to go through the scoring algorithm, and we're going to show you some of the techniques you may want to use on difficult cases, although most of the cases should be like a spot diagnosis. A few words about on-slide control, and then hopefully, if we speak very fast, we'll have time, the last 10-15 minutes, to go through some live cases to show you a little bit how we handle cases in digital pathology. Very good. So, Nobel Prize 2018 for the application of the complex system of second signaling for the immune system to defeat cancer. So here is an antigen presenting cell, and this is a T cell, and they converse primarily through the T cell receptor, which of course has a specific antigen recognition site. So the antigen presenting cell presents the antigen to the T cell, it recognizes it, and then there are second messages. Without the second message, nothing happens. And there are inhibitory messages, that's the PD-1, PD-L1 axis, not exclusively. This is one of the inhibitory axis, and the stimulatory axis, in this case here, B7-1 and the CD28. The result of it is then that the tumor cell, the T cell can affect an immune response against the antigen. Here it is a cancer cell who may also be able to present antigen and to present the ligand for PD-1 and inhibit these tumor cells. So the tumor cells might have learned how to keep the T cell at bay.
Inhibit the immune response against them.
The cell mediated. Okay, so what happens when we use an antibody against these receptors, PD-1, that's the example here, anti-PD-1. Well, we stop the inhibitory pathway and we affect the...
we enable,
Okay, fantastic. And then, of course, originally there was an anti-PD-1 antibody, but now pharma has developed also anti-PD-L1. So you just bind to the ligand rather than to the receptor, same effect. Cool. So that's the kind of thing. So in triple-negative breast cancer, really there are two immune checkpoint inhibitor drugs around. The one is an anti-PD-1 and one is an anti-PD-L1, and here are the names. And both of them are used in combination with some form of chemotherapy. So they're not using monotherapy primarily. The relevant trials for this use of this drug in triple-negative breast cancer is in the untreated, unresectable, locally advanced or metastatic setting. of triple-negative breast cancer, and atezolizumab in combination with paclitaxel. Now, because paclitaxel requires some steroids because of the effect it has when you inject it, they use NAB paclitaxel that's copulated with albumin, and that doesn't require so much steroids, because steroids are thought to inhibit the immune response. So that's why, although it's much more expensive drug. Anyway, these patients were treated, and you can see here the progression-free and the overall survival, and you can see the two lines, they are separating quite nicely, and this was the basis for an accelerated approval by the FDA in 2019. A little bit later, Keynote 355, that is pembrolizumab in combination with chemotherapy of choice of the oncologist in the kind of same setting, untreated, locally recurrent inoperable or metastatic breast cancer. And this, remember, is a anti-PD-1 drug. And again, nice separation, FDA approval in 2019. And here is a little timeline. By the way, I thought I'd put some abbreviation here. We mean M, this is metastatic, or E, early, or A, advanced triple-negative breast cancer. So in 2021, FDA approved Pembro. But while the approval for Atezo in 2019 was an accelerated approval, they kind of jumped some obstacles doing that. They approved this in accelerated setting because there was nothing else to give these patients, waiting for more robust data from the clinical trial. In the meantime, in July, Pembro reported full approval. Now the landscape is different because now there is a choice. You can give Pembro. So
and the clinical settings.
In the clinical, yeah, and therefore the bar for the FDA approval would have been raised. The clinical trial was IMpassion131 that unfortunately for Roche used not paclitaxel, but paclitaxel. And maybe this is the reason, maybe not, but the results were not as convincing. And therefore there was a voluntary withdrawal of the accelerated approval. Now, this is only in the US, because both in Europe and in UK, the approval was full approval, so that nothing changed. By the way, Emilia, you're much more knowledgeable than me about this, so if I say something incorrect, you should intervene.
I agree with everything you said.
Very good. So, so this is where we are. In the States, we don't use it, but in Europe and probably in a lot of other places, you know, it's used as an alternative for Pembro. Just put a screen here of what kind of things are happening in triple-negative breast cancer, because people have been trying immune checkpoint inhibitors in various settings. Remember, the settings of the original IMpassion130 is untreated, metastatic or locally advanced, etc., etc. So now, early triple-negative breast cancer in adjuvant settings, that didn't work very well. But remember that now this group of patients is enriched with different diseases, because these are now early cancers rather than late cancer. So they could be biologically quite different. Then this is a trial, ALICE trial, metastatic setting with anthracycline rather than with taxane, and there was a possible benefit. It was independent of PD-L1 status. Remember, both Pembro and Atezo in those early trials were dependent on PD-L1 status. You need to be PD-L1 positive for to benefit. Now, this is a trial IMpassion031 of neoadjuvant, so treating before surgery, Atezo plus sequential NAB, and then anthracycline in early. And that
and it's also what we define as early, because it's probably not having distant metastasis.
So again, I'm not really very knowledgeable
because
about this, but
then it wouldn't be treated in any case. So if it's resectable, less than 2 centimeter tumor,
exactly, that's probably the definition. And here you see that there is an advantage, you know, and the measure the unit of measure is how many complete pathological responses there are, and it's almost 70% with almost 50%. So quite a good improvement.
Again, in this setting, we give without PD-L1 status, and then there are these cases that we would use normally neoadjuvant chemo.
Yeah. This is a trial of first-line atezolizumab plus an anti-VEGF and paclitaxel. It's a phase 2 trial. Not so sure what happened there. People are not talking loudly about it. And this is a trial of carboplatin and atezo in a metastatic setting. And here there is an improvement. Here is the overall survival improvements. And the improvement is independent of PD-L1 status, so positive or negative, doesn't matter, but greater benefit for tumors that have high TILs or high tumor mutational burden. So kind of interesting snippets to tell you how the use of these drugs is going to evolve in our clinical practice. And I kind of almost always show this slide because it's a dramatic slide of a patient who is really destined to die. This is a patient who has had several relapses in a triple-negative breast cancer, heavily pretreated, now has a large sternal mass, you see it here, fungating, etc., combination of a tyrosine kinase inhibitor plus an immunocheckpoint inhibitor's complete resolution. So these are the kind of amazing stuff that could possibly happen to this patient. This patient would not have survived. Now, I kind of was hoping that this would be a little conversation, but I only have Adelina here to converse with me. But if any of you would like to unmute yourself and contribute, we're really welcome, because this is really more for everybody than just for me and Ade. So what is triple-negative breast cancer? And kind of think, oh, that's easy, you know, ER negative, PR negative, HER2 negative. But I think it's a heterogeneous group of disease. We know that from all those multi-omic studies, you know, proteomics, etc., etc. We know that there are probably at least 4 subtypes. They are listed here. But remember, and so it is possible that these subtypes may respond differently. And also they have different proportions of PD-L1 positive cases associated with it. So keep that into consideration. Currently, we are not subclassifying this tumor. Also, keep in mind that a little while ago, HER2, that's the antibody drug conjugate against HER2, has been used and has a license for the HER2 low portion of triple-negative breast cancer. So here is another little subcategory. May not be a very a biological category, but it's certainly a therapeutic category here. And I kind of put 2 bullet points here for Adelina to tell me about it. What about the ER low, HER2 negative?
So it's interesting because we were having a conversation during a breast course about this. So at the moment, at least in the UK, so while the other indications for triple-negative breast cancer, the oncologists are more likely to use this cutoff of 10%. So if it's less than 10%, I had a discussion at the MDT recently with an 8% ER positive case.
You were very precise.
They would go
8%.
They would go and treat it as per triple-negative cancer, but they wouldn't add an immune checkpoint inhibitor unless it's 0,
okay.
ER 0,
so they are
very good. Which in a way, now it depends, like Corrado was saying, with the classification as triple-negative breast cancer, what kind of methods we use, because we have the clinical usual methods, ER, PR, HER2, and
you know, interestingly, what is low ER? Because I can make a tumor low ER by just using the right antibody. It doesn't show up very much.
Yeah.
You know, so in many ways, it's almost like a classification of tumor as triple-negative breast cancer resides also in the hands of the pathologist.
Yeah.
I'll use a different clone. I'm sure this is going to be less than 1%.
Let's not forget about the other tumors outside breast cancer that show ER even at this kind of level.
So kind of this is interesting. And we had I have a little, I belong to a little journal club, breast journal club in the UK, and there was a discussion about it. And I said, well, you know, there is no real definition of what is triple-negative breast cancer. The oncologist would like to treat this patient as triple-negative breast cancer, but he has this, this now we don't forget about percentage. Now we use this bloody all-red score that I hate. And I was telling them, well, actually, each MDT can set that definition for triple-negative breast cancer. My MDT can say less than 10%, I call it ER negative. It's entirely up to you to negotiate with your MDT. So eventually, we could report ER negative or ER positive rather than giving this value, if you want to assist the oncologist in assessing the drug. What I didn't know was that the oncologist cannot prescribe, if we write in our report, ER weak positive or positive, even if we put a percentage there, that is not less than 1%. Okay, so kind of this interesting. And I put here the other bullet point. So what I wanted to say about this second last bullet point is that if you do genomic studies or expression studies, you realize that some of these low ER, actually, they look like a triple-negative breast cancer. They have the same patterns of expression triple-negative breast cancer.
There are even ER fully positive cases that on expression profiles, they have even basal
immunophenotype.
immunophenotype.
So, okay, so maybe this is to reflect on the fact that, as usual, our definition of what tumors are is a little bit not very precise. So this last bullet point also is something really real, because a lot of ER positive, HER2 negative tumors that are challenged by letrozole or whatever it is, they will come back as ER negative. Are they triple negative breast cancer?
So, yeah, I feel like the earlier the recurrence is, the most reluctant the oncologist is to think, oh, is this now triple negative breast cancer? Now we had cases that were recurrent after years, and they're happy to. Even today, I had a case that they asked for PD-L1 after the MDT. So, yeah.
And so it would be interesting to see what the data show, how this particular population of tumors, the ER low and the ER negative that were ER positive, how do they respond to the challenge of immune checkpoint inhibitors?
We have another comment here as well. So now we talk about ER low, but what about those that are ER negative but PR?
That's a very interesting concept. So, I mean, I have to tell you, those are really, really rare cases. And in all fairness, they do exist, but they're really, really rare. I mean, they are so rare that nobody should worry about it. In reality, they are not triple negative, because triple needs to have PR negative as well. Yeah. A lot of them are, most of the ones that we signal out as PR negative, PR positive, ER negative are actually a defect of our assay. Later on comes up with, but yes, it's an important point.
But actually, I've seen studies as well where you're right, they're very rare, but their prognosis is in between ER positive and negative. So they seem to be a biological subgroup. Even though we don't really know how to treat them.
They're treated as per ER positive at the moment. But
and also, while we're on this page, it is a very interesting proposition, because a lot of places still don't do PR. So they call something triple negative on the basis of 2 tests only, ER and HER2. Oh, what happened to the third one? Why we call it triple negative then? But anyway, that's just semantic probably. Okay. And this is my little scheme of why we could think about subclassified triple negative, because there are actionable categories. So of course, you know that these are rare, low-grade, special type, like acinic, all these type of things. They are triple negative, but these are not what the oncologists understand as triple negative breast cancer. But these are the triple negative breast cancer. And some of them are immune-activated basal, some of them are immunosuppressed basal. They have different changes. They are enriched with different things, and they will be more or less amenable to certain therapy. And I kind of raised the awareness of the luminal androgen receptor positive, because is at least one of these triple negative breast cancer that we can identify quite robustly. I may have a little example here for you. It's a little story. This is a usual core biopsy. Oh, look, there are goblet cells, a bit apocrine looking. It looks like a lobular carcinoma. Could be plaque, pleomorphic and alveolar, pleomorphic and apocrine lobular carcinoma. But beta-catenin and E-catenin, good expression, and ER, PR, and HER2 negative. Now, think about luminal androgen receptor positive, because you can diagnose it and it has a meaning. This is the androgen receptor, is positive. You could do also a CK7, because you should be luminal in phenotype, not basal. So, some of them have done them. Some of them are both CK7 and CK5 positive. I haven't had my head around this problem. I don't know why, but at least they do express CK7 as a marker of luminal phenotype. So think about LAR, because most lobular carcinomas, in fact, if you have a triple negative lobular carcinoma, that's kind of rare. Think about it. Think about something else, especially if you cannot demonstrate aberrant expression of beta-catenin and E-catenin. That's another case I wanted to show you. It looks like a ductal carcinoma NOS. And, you know, sentinel node biopsy, we do a pancytokeratin, because we use cytokeratin to hit the tumor cells in the node. If there is low volume disease, we may not be able to recognize it on H&E. It's easier on immuno. So we always stain the tumor with a pancytokeratin. Usually we use MNF. This was negative. Not to worry, let's throw some different cytokeratin. This is your CAM5.2, usually should be positive. We did A1. We also did a basal cocktail with CK903. They're all they were not completely negative, but they were really very low expression, very weak and low, and then focal expression. So we threw some more markers, and there is SMI expression. It's quite nice. So this is, I think, is an example of mesenchymal triple negative breast cancer. And think about it, where you find absence of very weak expression of the cytokeratin, so the epithelial intermediate filaments. Go and look for other intermediate. These cells, you know, they must have a cytoskeleton. What is the preponderant intermediate filament of this cytoskeleton? That may tell you it's more a metaplastic, it's more a mesenchymal type.
And it's a shame, maybe we should recognize this kind of differentiation more, because
is it
we're only looking for...
Is it important? I don't know. I think this is a slide that say that the therapeutic landscape for triple negative breast cancer is changing. PARP inhibitors are used more. Obviously, there needs to be some defect of homologous DNA recombination. Remember now, all the young women with triple negative breast cancer, youngish, are tested for BRCA, and if they are BRCA mutated, not quite silenced, methylated, but there is BRCA mutation, then the platinum-is and PARP inhibitors are treatment of choice. We talked about immunocheckpoint inhibitors. There are two drugs, anti-PD-1, anti-PD-L1. The mechanism of actions are different. Some cases respond to one and not to the other. It would be convenient for the oncologist to have both tests available, so that they understand, that they know how they can play with this chemotherapy. So you may want to do both PD-L1 tests. Remember that now we said very briefly, and the antibody drug conjugate for HER2 low in triple negative is available in, obviously, I think it's in second line, but nevertheless, that's important. There are now some interesting trials, for instance, HER2 plus immunocheckpoint inhibitors. I don't recall seeing reports of it, but I know they're going on. We spoke about things like luminal androgen receptor. They have much less complete pathological response on the conventional regimens or chemotherapy regimens, but they are more sensitive to something like testosterone block and paclitaxel, for instance. So in a way, it kind of is important that we tell them this is alarm. Okay, how are we doing for time? Ooh, we need to fly. So the companion diagnostic for atezolizumab is SP142. Here is a core biopsy stain with SP142. The nice thing about SP142 is that it's a high contrast marker. You can see it at low power. If you look at low power, I mean times 2 or times 4 in your microscope, you get a sense on whether something is positive or negative.
I have to say, it's probably my favorite PD-L1 marker.
Yes. 22C3 is a devil because you may not see much about a times 10 or even times 20, and then you put a higher power and you think, oh, look, there is staining, the immune cells. Okay. And that's also a larger piece of tissue, and you can see how well you see the staining. You need to watch.
This is the other one.
This is the other marker. You need to watch on whether the staining hits necrotic areas, but you can see this necrotic debris inside. But otherwise, you need to make sure that it hits the right thing.
I think with 142 happens less often that we get
22C3
staining and necrotic.
And remember that they don't overlap. They overlap for some cases, but they don't overlap to other. And that's the thing that you need to accept. Some immunocells and immune infiltrate are staining with one antibody. At the moment, this is 22C3. It could be the other way around, but the same areas are completely negative. So if you need to select for the appropriate drug, you need to use the appropriate companion diagnostic. And the reason for that are twofold. This is a diagram that came out of the blueprint studies, so that effort to try and normalize the use of anti-PD-L1 antibodies to detect essentially PD-L1 in lung cancer. And of the 4 antibodies, but this is to detect tumor cells, of the 4 antibodies, PD-L1 is the outlier. It marks much fewer tumor cells.
So yeah, so 142.
But sorry, 142. But that's for tumor cells, not for immune cells. And this is a little diagram that shows where the various antibody binds. And also, we don't really have a lot of information on the alternative splicing of this molecule and whether all immune cells have the full-length molecule or not. So the fact that you find some infiltrate that have staining with one antibody and not with the other may not be that surprising. Okay. Also remember that the 2 antibodies are interpreted differently. Importantly, the targets of our interpretation are differently. For 22C3, you look at tumor cells and tumor-infiltrating mononuclear cells. For the SP142, you look only at tumor-infiltrating cells, but also the type of immune cells are all-inclusive here, but they are really restricted to lymphocyte and macrophages, no plasma cells, no neutrophils. Yeah, that's kind of thing. And then also, what we count is different. Here is a ratio between the total number of positive cells versus the denominator, which is the total number of tumor cells. Here is an area ratio, the area of tumor tissue occupied by the immune cells. So if you look at some post-hoc analysis, that's of the original trial in Passion 142, you realize that there is an overlap. So most cases are diagnosed correctly with both antibody, but there are some cases, a significant proportion, 10% and 17%, that are not concordant with the 2 antibody. And then, although this is a little bit disingenuous, because the 22C3 threshold here was set at CPS 1, while now the CPS threshold is 10, so it's slightly different. Nevertheless, and more importantly, if you select for 22C3, there is no difference in the 2 arms. But if you select for 142, there is a difference. So this signifies that you cannot use these 2 markers interchangeably. You need to use the right one. Okay. And that's kind of an example on how you should equip your request form. You need to, don't say just PD-L1, you need to tell them which drug do you want to use. You need to kind of make an effort. So what do? Ultimately, talk to the oncologist. They are our customers, really. However, do think that if the first test you do is negative, consider to reflex with the other one, even if they order you only one. What tissue to use? Do you use core biopsy or excision biopsy? Do you use primary tissue or metastatic tissue? How many times do we repeat testing if we don't like the results? So
sometimes this is quite limited because you have patients going from one place to another. They have only the core biopsy. The trouble is when you have a bone or a liver biopsy that oftentimes
so I think
negative.
I think you should think that when you look at data, it is less likely to have PD-L1 positivity in metastatic tumors at certain sites. For instance, liver, very low PD-L1 positivity, bone, very low, skin, not so high. And in general, metastatic site overall are less positive than primary. But regardless of whether you test the primary or the metastatic, the patient does respond to the drug. So you don't have to have a PD-L1 negative metastasis, a PD-L1 positive metastasis to respond. And also, if you taste, I think maybe we have another slide, if you test a small amount of tissue, because of heterogeneity of PD-L1 expression, you may hit negative areas, which you would instead average out if you have larger amount of tissue. So this is the study we done a long time ago. And we demonstrated that if you test core biopsy and is PD-L1 positive, even if you retest the excision, that's very concordant. We never found discordance. So a positive core biopsy for us triggers an action or treatment. But if the core biopsy is negative, we go to the excision and retest the excision, in a proportion of cases, the excision is positive. So we can give the drug to the patients. So it's worth thinking about it. We like to test core biopsies because they are better preserved, better pre-analytic. Also, they are small amount of tissue, so counting is easier than
at least if they're breast. They're not preserved.
Okay, so what about the assay? The assay has got is an on-label assays. You can't tamper with it, and you need a Ventana immunostainer. If you don't have a Ventana immunostainer, you will deliver a laboratory developed test. It is important to understand that the test is not just the antibody, but also the chromogen. So whatever you do, if you don't have a Ventana autostainer, you will need to reproduce the same analytical performance that with the chromogenic Ventana chromogenic system. As I said, it's really nice. It's really contrasted. You know, there's no half tones. So these are really positive cells. Here it looks like an infiltrate that is just at the periphery of the tumor with a little bit of percolation inside, but almost excluded. Yeah. And you can recognize two cell type here. The dots, I think the dots are most likely lymphocytes, and they're quite dark. And then the dirty kind of granular, blah, 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 blah. And these are probably macrophages. And then you can also recognize granulocytes and plasma cells. They do look different when they stain with this antibody. This is a higher power of paranuclear dots, or perhaps
this is lovely. Yeah,
macrophage here. Yeah. It can stain tumor cells, and that's what tumor cell staining look like. Tumor cells are not part of the algorithm, and don't panic, because most cases of tumor cell staining are also immunocell positive. So in many ways, if you find tumor cell staining, it's kind of
positive tumor
in this tumor. So any immune cells, we said, including polymorphs and giant cells, must score only cells related to the invasive carcinoma, not to the DCIS, not to the normal breast.
Sometimes it's difficult to
Very difficult.
tell.
What is important is that the score is the percentage of the area occupied by the immune cells, and I will show you how this works. And the score of 142, regardless of what tumor type, is divided in beam. Ventana is divided in beam. The beams are 0, 1, 2, and 3, and these are the cutoff for the beams. Less than 1%, 1 to 5, 5 to 10, and more than 10. For triple negative, the threshold is here. For other tumors, maybe here or here, it doesn't matter, but this is where we know. So we need to recognize essentially low-level expression because 1% is quite low. That may be tricky. So techniques for that. So one is you can, in your head, or practically, if you take a photo, divide the area in 100 separate squares, because if I can fill up one square with the area occupied by the immune cells, that's 1%. I'm home, okay? So, and we can see if we have a little bit of time how we can do it on core biopsies. You know, we need to have an understanding on how big is the area of tumor tissue and how big is 1%. And then perhaps in our head, we can fill it up or not fill it up enough with enough cells. And this is some slides provided by the endeavor of Emilia and Martha, who patiently encircled each positive immune cells. And you see the granules are cytoplasmic, but the immune cells is bigger than just the granule. There is no nucleus cell.
So it's the area occupied by the staining immune cells.
And then put a grid on top of it, and then pick up all these little cutoff and pile them up into the area, into the percentages here. And this is 2%. So look, if we go back, something that looks like this is 2%. And they've done it for hundreds of cases. I suspect because they didn't have very much to do, and the television didn't have that funny
I doubt that.
sequence. I don't know.
We're all very busy.
But thank you for their effort. And here's another example, you know, much sparser here. Again, grid on top of it, pile them up. This is less than 1%, less than 0.5%. Okay. And they produce a nice atlas, which is available online, to give us a little bit of an understanding visually, what is 1%, what is 0.5, what is 2%, etc. Now, what happens if you have a large area? So this is a large block. So try to divide these in more or less equal size areas, you know, squares. Of course, these two, well, you need to merge them together and make it a one. And then on each one, put a grid, and on each one, make up a number. So I'll show you here, for instance. Sorry, this doesn't render very well. But let's say, for instance, this square is 9%, this is 0.5, whatever it is, the number. And then add them all up and divide them by the number of squares. And then you have the average. In this particular case, was 3.3 positive. You know, that's a way of getting yourself out of this kind of prevalent heterogeneity, a bit positive, a bit negative. How do we go about it?
Or with the bigger area, just like this, you could just try to find out how big the surface is, and then try to find the square that represents 1%, and then I think this is our often used method on digital.
We often use that. You know, the beauty of digital is that you can draw on the slide quite nicely, and it tells you exactly what is the surface area, and then you can make a square of 1%.
I think I used a lot of this on glass slides, or when I have a core, it's much easier to divide it into
smaller units. Okay, so this is the atlas I was telling you about. I think it's worthwhile because it's organized in progressively higher percentages, you know, and that is a visual representation of what these numbers should look like, because I think ultimately, none of us will have the endurance of Emilia and cutting out each little
they've done this with us.
They've done it out of love. But this work means that I can now understand that that type of pattern means 1%, that type of pattern means 5%, and then I can do the averages. Cool. This is available online, I think.
Yeah.
Okay, just a few words about monitoring quality and on-slide controls. We now use more and more control cell lines with known expression. And I must say, at a glance, I realized whether the assay has worked or not. But traditionally, everybody uses tonsils, which is a great source. Our experience is that if you don't fix well and then do long processing of tonsil, you never get a picture like that. This is beautiful, and you can see strong expressor, intermediate expressor, and low expressors. These are germinal centers. What you see here are the tingible body macrophages predominantly. These are the interdigitated dendritic cells within the crypt epithelium. Here you see the surface squamous epithelium. That's negative, you know, and there's a lot of negative areas. And these are the interfollicular areas with lymphocyte. I hope I have higher power. Yeah, there it is. You saw negative surface epithelium, crypt epithelium. The epithelium is negative, but the dendritic cells are very positive, spiky. You see all the spikes. And these are the tingible body macrophages, and these are the little dot-like lymphocyte staining. There are some plasma cells as well. Higher power of the rest. And I think if you don't have it, you should get this mini review that Adelina and Abir have produced, because there is a condensation of a lot of the things we've been discussing. I think it's a very well-written review. Well done, Ade. And Ade will be delighted to send you a PDF if you ask. Great. I think that was my last slide.
Surprise cases.
Okay, so yeah, we haven't prepared. Okay, 4 biopsies, very good.
For everyone.
Okay, so
Well, is this a triple negative? Well,
we went on. Okay, so interestingly, look at the H&E, because the H&E will tell you what is the surface area of the tumor tissue. You remember, this needs to be tumor tissue, not necrotic tumor, not area of tissue with benign epithelium.
I think in this case is all
most.
Usually in core biopsies we have, if I do have a significant area that is no tumor, I tend to exclude it.
Yeah.
Because sometimes it just feels like it's the edge of the tumor. So because
okay, let's
I
take
know
the PD-L1. Okay, so that's our control on the top. And
have a look. It's a bit of a
okay.
Yeah.
Okay, we think it's worth okay. Yeah. And then okay, let's have a look at this case. Okay, nothing to see.
Nothing to see. I mean, I would have seen it. We would have seen it at this power.
Do you think there is a little bit of staining here?
Let's see. Not really.
Not really. Okay.
So it's 0.
So I would say 0. Do look a little bit closer, 1 or 2 areas, just in case we are missing very, very low level staining, but there is a
I think the only way we would miss it if we would have just single cells.
Single cells. Single cells we don't see. Yeah.
Yeah.
Okay, so this is
it. Can happen.
Yeah.
It can happen.
Yeah. Oh, that's a large slide.
I hope we have some more exciting.
Okay. Again, tumor tissue, you can see where it is. Just have a look on whether there is necrosis, because you need to stay away from it.
And I think this is not DCIS. I think it's just tumor that has this pattern.
Yeah. Okay.
So we need to be wary. So not really in situ. I don't think so. Just invasive everywhere. That's another thing we need to be wary of.
Okay, PD-L1.
The controls seem to have worked, right?
Yep. And let's look at the PD-L1. Oh, here there is
some
very faint stain. There it is.
This is
okay.
Okay, so it looks like it's at the periphery.
So,
if anything.
First thing you need to ask yourself, are these immune cell staining, are they related to the tumor? And the answer is yes, they are very in close proximity to the tumor. Remember that we don't really have guidance on what is related to tumor or not related to tumor. But Agilent, in their 22C3 interpretation, has provided that times 20 rule. If you put it in the tumor in the center of the times 20 field, anything around it, that area would be considered.
Yeah, so this is a times 20 field, so
yeah, more or less. So that yes, it's involved. So you have
but this is very
this is very difficult, Ada.
Yeah, this is
because this is I think it's probably at the peripheries there is more than 1%. The real trick is going to be whether the same amount of staining there is also in the center of the tumor.
Yeah, so to me it looks like it's all periphery, but maybe there is.
There's a few dots here. Yeah.
So of course you need to check is the staining is genuine, and we see the same pattern dotted. It's mostly lymphocytes, probably in this case.
Yeah.
But I do not think
so.
You see.
So there are areas of complicated. So I think a case like this, you should approach it by dividing it into manageable areas, possibly of equal size, and then maybe help yourself with the atlas by comparing pictures and say, well, how much area positivity I'm going to give to each one of these regions, and then make a total. I was also going to ask you, you know that there is this staining here at the periphery. Is this pigment or is it real staining? Because that's the only thing you need to be wary.
I think it's dark enough.
Yeah, it's
and
real
it's
staining.
fine enough to be. It would be nice if we had an example. This is not real, of course.
No.
Is associated with probably necrosis or intravascular.
Yeah. Okay, so how would you tackle this case then?
I think I'll try to, like you said, divide it.
Yeah.
Yeah.
Shall we just show very briefly what 1% look like? So let's
Just
take
the area.
Let's take an area. So let's make up a. I know this is not very precise, okay?
Yeah.
But this is a kind of, and it says here area 204 micrometer square. So
we need 20. 2.04.
Okay, let's call it 2.0. Okay. Now, I find this very useful. So take this one. Oh, just a moment. Oh, I made some mistake. Okay.
Yeah, I don't know if we can.
How do you move it? No, you don't move it. Okay. You can see the area we need to fill, okay? And then let's go in the areas that are rich.
You can create another one here.
Okay. Shall I create another one here?
Yeah.
Good idea. How much was it?
2.0. Go more.
One.
You're at 1.
2. Okay. This is our target. Okay, very good. Okay, so all of these already fill a little bit. And then there is a little bit here.
That is quite significant. Then you have.
And then here, there is quite a lot more.
And again, you need to remember, it's not the staining that you use to fill up, it's
the whole cell.
The size of the cell staining.
You need to imagine the size of the cell there. So there is staining here.
Yeah.
This is a difficult case. I kind of get the impression this is going to be positive at the end of our endeavor, yeah?
I have the same impression.
Yeah.
Because even only from this lower fifth, I would say, of the tumor,
we may fill up all of it.
Yeah.
Okay. So this would be a case where I work on it, I make up my mind, and then I call my colleague and say, well, what do you think of it?
Yeah.
This is what I think. Probably will say positive. Yeah. You will need to spend a little bit more time. We are 10 more minutes. We can see another couple of cases.
Okay.
Yeah.
Wow. Now we have an extra H&E, or maybe we put both.
Lymph node.
Wow. Yeah, this is interesting.
Yeah. Yeah. So this is all tumor with a few lymphoid.
Now, this is one of my questions. Yeah. If it stains only these, you would still not take it into account, because these are definitely residual, aren't they? I mean, they're probably.
Are they?
They could be reactive as well to the tumor.
To the tumor. It looks as if there is very little residual lymph node here.
Yeah.
No?
It's just some carcinomas have these patterns that of metastasis.
Okay, let's have a look at the PD-1. see.
We also have this.
What is that?
I think it's
we
the
put
piece of
both
primary.
Primary. Okay.
So the
Okay.
same tumor, hopefully.
Yeah. And
So
yeah, we put both.
Okay.
Okay.
let's look at the node because it's very interesting. So this is one of the dilemmas, but in places we've got tumor cells going even into the follicles.
You think these are follicles, yeah?
Yeah, or then we have this, which I suspect maybe this was some sort of.
Well, if these are follicles, they should be CD21 or CD23 positive. You could stain and see whether there are dendritic cells. You know, if there are dendritic cells, then maybe you should say, no, I won't count the staining in the follicle.
But if we look closely, there
are intermingled here.
Yeah.
This would be 1%, more than 1%.
So they're
Yeah.
immune cell staining.
Mm.
But even so, they're so surrounded by tumor that
some people
yourself.
would take a view that the whole lymph node is no longer a lymph node, so this is just tumor tissue, and they would report everything. Some other people say, I only report immune cells that are touching tumor cells.
Or within some sort of desmoplastic stroma developed.
Yes, but inside the lymph node, I will only report immune cells in continuity with the tumor cells. But I'm curious to see what happened to the primary.
This is the primary.
Oh, yeah, there is something.
Yeah.
But this is maybe
looks below. A
below.
bit. Well, again, it's interesting because you have all this heavy immune infiltrate and also structures that are similar to the node. So maybe they're not that part of node structure. Who knows? I mean, this is not the lymph node. This is just lymphoid infiltrate.
So that's quite a challenging case. Again, I think I would be patiently dividing these areas in manageable chunks and assess each area, and with a piece of paper, draw a total. I think the primary tumor is negative in my opinion, as a ballpark figure. But it requires a bit of more work. The metastasis may be positive, so quite controversial. But what do we do in this case? We could go and look for another piece of tissue, if you so wish, or you can tell the oncologist, this is my findings. No? And we have 6 more minutes. Do we see another case? Perhaps a core biopsy that is more easy?
Bless you.
Or that's a big... Yes.
Well, this might be lymph node again, or no?
Maybe not. Looks primary.
Breast.
Yeah.
But with heavy lymphoid infiltrate in places. Okay.
Okay, a low power, I already see considerable staining.
Yeah, so this is, you're right, this is easier. Oh, this is nice because I think we have tumor cell staining here.
Okay.
So
this is more complicated for your head, because now all this brown staining, not all of it is countable. Oh, look, here there is an infiltrate around the normal, or is this normal? Or no, this is tumor.
No, this is tumor. I don't know if it's intravascular, but you also have a lot of definite.
Yeah.
Wow, and here as well, I think there are some immune cell staining. I think I did report the one, but I think it wasn't breast, to be fair, with tumor cell staining.
You see how much heterogeneity there is in the tissue.
Yeah.
And that's not an uncommon finding.
And this takes us to your point of
if negative,
trying to repeat.
If negative, and you have more tissue, do it on additional blocks. Yes. I kind of feel less confident to call this positive because of the
So yeah,
visual impact of the tumor cell staining.
yeah, I think this predominates really. So would you call this negative? At the same time, you have a lot of immune cell staining here.
Cell staining. So what is the answer? I don't know. Part of the tumor are really expressing, there is a crosstalk between the immune cells and the tumor here.
And it's possible that this is some sort of edge periphery of the tumor, and there's a large mass, and then...
And again, to give us a ballpark understanding of what we need, the area of this thing is around 22, 23. So we need 0 point something like this, kind of. Well, we can easily feel that little 1% here. Okay,